Okay, so I can start?
Yep.
Okay.
You're good.
So as an FYI, I have not seen the test, so I don't know what's on the test, but I'm going to hit what I think are probably highlights or whatever. So there you go. It's always good. Anytime, I hate putting this on the record, but I'll do it anyway. You probably know from previous tests. If Dr. Warner has a slide in his PowerPoints that he has information written on, know that information. All right? Pure and simple. Make sure you know any information that he has put on there, especially if it's a slide that he has kind of handwritten or put other stuff on that made notes on. It's important. You probably already knew it. I'm just going to emphasize it again anyway. Make sure you know whatever he's put on the slides. So on most of these sections, so whether it was orbit, infratemporal fossa, not so much TMJ, ear I guess as well, it was all areas that there were boundaries and limitations for. So make sure you know a lot about that. I didn't put the slide up that had orbit. I'm not going to say that. Know the boundaries and stuff or whatever. I think it's important. I'll go through. So I put this up for lab purposes more than anything else because I've had multiple people ask me relative to the septum and the tarsus. So I think, I like that, I think. So for practical purposes, the models actually should have kind of the eyelid still kind of in place or whatever. So I think it's a matter of, you're gonna have to have something outside for septum versus kind of more middle portion for tarsus. Tarsus is actually where smooth muscle of the eyelid is actually attached to, whereas the septum is what the connective tissue structure actually attaches kind of the eyelid, if you will, to the bony margin of the orbit. So septum would be the outer aspect, the tarsus would be this inner aspect in here. Okay, so I think that would be an arrow pointing out here versus pointing into the middle. Hopefully, that will be the case. Put this in here for a reason. Just know the information that's on this page, I guess, is the biggest thing. Like I said, anytime you see something like this and there's another little note down here about the conjunctival sac, there's the space between the bulbar and palpebral conjunctivas, that always grabs my attention. I think that's why I put that on there. Same with about the check ligaments, Make sure you understand what their function is. Okay, when I put stuff in red, I put it because I wanted to make sure that you know about that or whatever. So there's a couple things that he made mention of. I think it's on the next slide or somewhere, or no, it's actually maybe on this slide. So that was about he referred to it as the fascia bulbi. I would know it also as the vagina bulbi, tendons capsule, know all three of those names or whatever. It was a structure that's used to attach to the muscles, and he made the big point about the glass eye. So it holds a glass eye, glass prosthesis in place. So make sure we know that nice little fact. Until it's Sunday. I'm ready to be talking or whatever. I believe I put this slide in here just kind of, it's also for lab purposes, is remembering what muscles are in which parts of the orbit. So on the lateral aspect of the orbit, the only muscle you really have there would be lateral rectus. Superior aspect of the orbit, you've got both levator palpebrae superioris more superiorly. Below that would be where the superior rectus would be. So there should be two muscles kind of almost like right on top of each other. In the medial aspect of the orbit, more superiorly would be the superior oblique muscle that's going to wrap around through the trochlea. You go attach the eyeball. More inferiorly in the medial part of the orbit would be medial rectus. And inferiorly you would have inferior rectus, kind of more superior if you will, and then inferior to that going across the orbit would be where the inferior oblique would be. I'll probably have another view coming up of that. So you got 4 rectus muscles, so 7 what we call extraocular muscles of the eye. 4 rectus muscles, 2 oblique muscles, and you have to remember that levator palpebrae superioris is part of those extraocular muscles of the eye. because that'll make a big thing whenever we come up to the extrinsic, extraocular, what I'm talking about. But just keep levator palpebrae superioris in there, because when it comes to innervation, it's going to get innervation just like these muscles will. So if there's a deficit, as I'll talk about in a minute, remember, don't forget about that muscle. So I'll talk about the innervation, and everyone should know at this point, LR6, SO4, 3. So it's all about knowing lateral rectus, superior oblique are the exceptions. So in here it talks about a couple of different things. So the rectus muscles act as retractors. So what that means is they prevent the eyeball from bulging forward, from protracting. Remember, it's always about opposites. If you're a retractor, you're preventing what? Protraction from happening. Does that make sense? Okay. Versus the obliques do the opposite. The obliques act as protractors. So what do? They prevent retraction. Okay. Thus keep the eye in balance because of that. So the rectus muscles resist protrusion of the eye, bulging, while the obliques act in the opposite manner. They're going to resist retraction. So that's a good fact to know. The reason I copied this and put it in was just kind of getting a feel for what the different muscles do, and obviously their innervation. But there are certain patterns of innervation, patterns of action I want to go into that he's stressed about. I'll get to that in just a second. So here again is that same thing with about the muscle functions. Recti pull posteriorly, the obliques pull anteriorly. There's talked about the fat that's inside the orbit, how it also pushes the eyeball anteriorly. So the eye is held in position by these different muscles and by the fat. And so what prevents the eyeball from sinking back into the orbit is two things, the obliques and the fat. Okay, that's from going posteriorly. Recti prevent it from going anteriorly. The obliques and the fat keep it from sinking back into the orbit in the posterior direction. Okay, so about the innervation, this should be something. If anybody misses something about the innervation, it's going to be a bad day on the test. Okay, LR6, SO4, 3. So I guess the same thing. All right, so this slide helps kind of show that. So there's a couple things you want to make sure you know about this. It talks about the innervation pattern. Then it shows you movements relative to the different nerves and the different things that are going on. So if you understand that cranial nerve 6 innervates lateral rectus. So lateral rectus is one that's involved with kind of lateral, and also kind of gets, if you will, lateral and probably a little bit help with inferior. Cranial nerve 4, trochlear innervates superior oblique. The superior oblique is the down and out muscle. So down and out. So basically, if you lose 6 and 4, you've limited somewhat your ability to look laterally and a little bit about down. So what would the eyeball position be ended up being? Well, you'd be in a little bit different position. You'd be kind of the opposite from it. You'd be more medially and directed upward. Okay, it's the opposite. If you lose cranial nerve 3, so here's the pattern for 3. It's doing most of the, if not all, of the superior direction, a lot of medial direction. So the eyeball tends to be kind of laterally and downwardly positioned, because these two muscles and nerves still function. So this slide was all about trying to get you to understand if you lose certain nerves, what will the eyeball be positioned in? Because remember, if you lose the nerve, that means you've lost that action. So the opposite muscles, the opposing muscles, still work. The reason why if you lose 3 and the eyeball will tend to be positioned is because these two still work, and they will pull unopposed. So a couple things relative to dysfunction of 3. The eyeball would end up being positioned this way, but you also notice how it's got this, looks like an enlarged eyeball rather than this. It's not the eyeball's enlarged, but instead what's happening is it's exophthalmic, it bulges. That's what that exophthalmic means. I need to move that. Exophthalmos is bulging of the eye. Okay, so if you lose 3, it tends to bulge, strabismus, you have a little squint associated with ptosis, drooping of the eyelid. So I would make sure I knew this slide and what's going on with these different, particularly nerve lesions, and what would result because of that. Okay, so a couple of facts relative to blood supply. Remember, all the blood supply that's coming into the orbit is going to be coming from the ophthalmic artery. You know, the ophthalmic is a branch of the internal carotid artery. So it comes in, you're going to make sure you know that the ophthalmic artery travels with the optic nerve through the optic canal. You know, there's a foramen, if you will, optic foramen through the canal into the orbit. And then it's going to give off branches that I don't think you've got to worry about, but the branches are all named the same as the nerves that are present inside of there. You can see there's branches that mimic the frontal nerve. There's supratrochlear, supraorbital. There's a lacrimal artery. There would be branches just like the nasal ciliary branches or whatever. The only other one I want to mention too is coming off from the ophthalmic artery is a branch called the central artery of the retina, central retinal artery, wherever you want to see it or refer to it as. Remember, this artery that comes through, obviously it's going to the retina, but what it does is it travels into the optic nerve and travels right through the middle of the optic nerve going to the retina. So a branch of the ophthalmic artery traveling with the optic nerve to give blood supply to the retina. Typically to see it, you would have to cut through the optic nerve. When you cut through the optic nerve and take a look, there's literally just like a little pinhole right in the middle of the optic nerve where you see the central artery of the retina. Okay, easy enough. Branch of the ophthalmic artery, going to the retina. So that's what's getting talked about the artery. The veins, I wouldn't worry so much about any of the veins, at least for this part. We'll talk about the facial vein drainage in a minute. So again, what I mentioned here was a couple of things to be aware of. Optic contents going into the orbit, nerve-wise. So you've got multiple nerves going in there, either through the optic canal, cranial nerve 2, or you've got a series of nerves going through the superior orbital fissure, cranial nerves 3, 4, V1, 6. All right? So a lesion, a tumor, something at the optic canal foramen would cause what? A problem with vision, because it would affect the optic nerve. A problem with cranial nerve, or something if all the structures, all the nerves traveling through the superior orbital fissure were affected, what would be affected? It'd affect all movement of the eyeball, because that would be 3, 4, 6. So you couldn't move the eye. You'd still be able to see, your vision wouldn't be impaired, because cranial nerve 2 would still be fine. And the other thing you would affect would be V1. What does V1 do? Purely sensory nerve going to what? Lacrimal, frontal, nasal ciliary. So it affects sensation to things like the forehead, nose, multiple areas. But I'm trying to get you to understand the difference between an optic canal lesion, vision would be affected, superior orbital fissure lesion, what would be affected? Movement of the eyeball, and sensory from V1. Okay? Yes?
If there's a lesion though in the optic canal, would it also affect the artery?
You would, but all I'm talking right now is just nerves. I mean, if you lesion at the superior orbital fissure, you'd affect arteries. I mean, you'd affect all kinds of other stuff. I'm just trying, nerve-wise, that's what I want you to know. I don't think you have to worry too much about blood supply for here, other than just knowing everything's coming from the ophthalmic artery. And then central retina of the artery. Central retina of the artery. It's weird. Central artery of the retina. My mind is saying, you're not supposed to be lecturing on Sunday. What are you doing? Okay. The other thing I would say about blood supply, because I made this the point about this, is facial vein drainage to the cranial cavity. So obviously this has come up in multiple things about, infection on the face, traveling back to the cranial cavity, and, using stuff in the orbit. So for your purposes, I would take this slide, and I know all this stuff down here about from face, facial vein to the cavernous sinus. So what can drain back? Superior ophthalmic veins, inferior ophthalmic vein, know this slide, know what can drain back to it. Okay, so if you know these, then essentially you would probably know what didn't drain. back there. These drain the cavernous sinus. Some of this is for lab purposes as well. You're going to make sure you know. All right, so V1, the orbit's a lot about V1. So V1 going through the superior orbital fissure, and then you know it will branch into 3 direct branches: lacrimal, frontal, nasociliary. Those are the 3 direct branches of V1. Because they're direct branches of V1, that makes those purely sensory nerves. Now, they can have some autonomics that will hitchhike onto it. Let's don't worry about that. We'll do more about that when we do pterygopalatine faucet. Those are the 3 direct branches. You need to know that the frontal nerve will divide into supratrochlear, medial, supraorbital, lateral. Lacrimal, there's no branches you have to be aware of. And then for nasociliary, I think the only thing you really have to know is anterior ethmoidal. I don't know if these, I would just know, I think it makes it easier. The nasolacrimal ends in 2 terminal branches, anterior ethmoidal, infratrochlear. Because that helps you remember that infratrochlear is a branch of V1 and not from V2. I don't think, lab-wise, I don't think you had to know it. It didn't make sense to me to say there's anterior ethmoidal and not see infratrochlear because it's right there with it. So if nothing else, just know that fact, so it'll help you understanding what are branches of whatever. Maxillary nerve, you know, is going to go through the rotundum. It's not doing that much in the orbit, other than infraorbital going across the floor of the orbit. Okay, so nasociliary, so you can see the frontal nerve lying superior to levator palpebrae superioris and superior rectus. And the lateral aspect of the orbit would be the lacrimal nerve, headed right over the lacrimal gland. Remember, it's a sensory nerve. It's not so much about the function of the lacrimal gland, it's sensation from the lacrimal gland and out onto the skin of this portion of the orbit. Frontal, and then if you look on this side, taking away these nerves, here comes nasociliary. So nasociliary will come along, give off some branches that you don't need to know, and then way up here would be where anterior ethmoidal and then infratrochlear would be located. So it's located, if you will, inferior to really these 2 muscles, and then lateral to superior oblique and medial rectus. These branches come off and really pass between those 2 muscles. I don't think that's a big deal, but I kind of know this thing that he put on this slide as far as what the nasociliary nerve does. Okay, for the lacrimal apparatus, making sure people understand what's going on with this. So here's the lacrimal gland where tears are going to be produced. So tears will be produced on the lateral aspect of the orbit, and then as you blink, you're going to, it's kind of like windshield wiper, you're going to wipe tears towards the medial aspect of your eye. So things are formed here and then drain this direction. All right, so what happens is, make them in the lacrimal gland, they drain across, or go across the eye, and they're going to be collected over here in the medial canthus or corner of the eye. So there's 2 structures right here to be aware of. It's more lab-wise as much as anything. There's a little bump or mound that's going to be right here that's called the lacrimal papilla, and then there's one on both lids, and then in the papilla there's a little opening called the lacrimal punctum. So the punctum is the hole or opening in the papilla. So the tears will drain into the punctum initially, okay? They'll then drain through the lacrimal canaliculi, go into the lacrimal duct, eventually to the lacrimal sac, and then down in the nasal lacrimal duct will be carried down and drain into the nasal cavity. All right? So it's all about the first place the tears go into is the punctum, then to the canaliculi, the lacrimal duct, lacrimal sac, nasal lacrimal duct. That's the passage or pathway, if you will, of tears out of the orbit. Easy enough. Just especially didactics in the lab, make sure you understand the bump is the papilla, the hole or opening is the punctum. And then also, I don't think I've got on the next slide, I wrote on here, sorry, there it is. The lacrimal caruncle. Lacrimal caruncle is basically kind of that crud you see in the medial corner of the eye. So this structure represents sebaceous glands that are present inside of there. Just remember the lacrimal caruncle, these sebaceous glands secrete an oily secretion that functions to trap dirt, prevent it from irritating your eye, captures the dirt, and that'll be carried off by the tears as they rinse towards this part. So tears can come over, pick up the oily secretion with the little dirt that's inside of it, and drain it off. So there's where the little lacrimal caruncle would be. I think what I just said is summarized on this slide, so I'm not going to go through that. Okay, any questions about orbit? Yes, sir?
Where would that lacrimal duct be?
The duct is where the two canaliculi drain into. It's this structure right here.
Okay.
And then the duct goes into the sac goes into the big nasolacrimal duct, which then goes down to the inferior meatus of the nasal cavity. Sure, they talk about it. If not, we will. Let's see, I've got nasal cavity lecture. It's why your nose runs when you cry really hard. All your tears go down to your nose. Y'all didn't know? I mean, did you not say that? I mean, come on. That's why your nose runs. If you really get big crying fit, it all drains right to your nasal cavity. That's why your nose runs. But typically, you don't have enough tears going into there to make your nose run. But you can think about other things that make your nose run. So things like if you're eating spicy food, now that comes from something else. It's a different stimulation. Okay, infratemporal fossa. Infratemporal fossa, TMJ, will have a lot of stuff because obviously this is stuff that not just stuff that's important to you. I was going to correct that. All right. So know the boundaries of the infratemporal fossa. If you know boundaries for anything for this test, know the boundaries of the infratemporal fossa, and know what the bony structures as well. So don't just think, oh, the lateral boundary is the mandible. Know that it's the ramus of the mandible. Don't think superiorly, so I want you to make sure you know superior also is referred to as the roof of the infratemporal fossa. All right. Don't think it's just sphenoid or whatever. You got to remember that's the greater wing of the sphenoid, the infratemporal crest that's on the sphenoid bone. So make sure you know these boundaries. The other thing is, again, this is an important slide. Know what the infratemporal fossa communicates to. So typically what you can think of is almost directionality as well. I did put up here, but it's easier to think. So superiorly is going to connect to the cranial cavity via foraminal valley and spinosum. Anteriorly, it goes to orbit through the inferior orbital fissure. Superiorly, I guess a different route, if you will, it's going to the temporal fossa. I think cranial cavity is what I remember being superiorly as well. Immediately goes to the pterygopalatine fossa through the pterygomaxillary fissure. So know the communications, the boundaries of the infratemporal fossa. This is one of those things where, like orbit, I don't know that I necessarily like making people know it, but this is stuff that you've got to know because I guarantee you this will be on board exams as well. It's not just being tested here, you'll see it on national boards also. Infratemporal is kind of important. Okay, so this slide for maxillary artery, you're going to make sure you know all the facts on this slide for maxillary artery. So you know that it's divided up into three parts based upon its relationship to really the pterygoid muscles, okay, particularly the lateral pterygoids. So the first part is what's referred to as the mandibular part, and it's just, as the maxillary goes deeper behind the ramus, it's going to give off branches there before it actually gets to kind of where the pterygoid muscles are. There's 5 branches on the first or mandibular part. I'll talk about some of those in a minute. The pterygoid part is the part that lies either superficial or deep to the pterygoid muscles, because really what it is, about 50% of the time the artery travels superficial to them, about 50% of the time it goes deep to them. And it can be one way on one side, different on the other side or whatever. And then the pterygopalatine portion of the maxillary artery is after the artery has gone through the pterygomaxillary fissure, it goes into the pterygopalatine fossa. The only ones you really got to make sure that you know about, well, I say 2 of them. one that you can actually see in the infratemporal fossa, and that's PSA, posterior superior alveolar, because it kind of comes back out the pterygomaxillary fissure to go into the maxillary buttress. And then for your purposes for now, although there's multiple other ones in there, make sure you know infraorbital artery coming off the third part of the maxillary artery. For each of the portions, it's knowing different branches. So for the first part, lab-wise, really focus on middle meningeal, inferior alveolar. It never hurts to know these others, so I'll do it backwards because it's the direction they go. So you can learn it as, instead of edema, adema, A-D-I-M-A. You almost never hear me talk about mnemonics, but A-D-I-M-A. Anterior tympanic, deep auricular, inferior alveolar, middle meningeal, accessory meningeal. All right? You won't see deep auricular, anterior tympanic on the models. I wouldn't expect that. I wouldn't even look for those on practical. Middle meningeal is fair game. We'll talk about, and everybody should know at this point, middle meningeal because going through the loop of the auriculotemporal nerve. Inferior alveolar going down to go into the mandible along with the same name nerve. The pterygoid part, or second part of the maxillary artery, is really about branches going to the muscles in the infratemporal fossa. So there's a mesenteric branch, there are pterygoid branches, there are temporal branches, particularly we'll talk deep temporal, and then there's a buccal artery that's going to go to the buccinator muscle as well as going to the cheek. When you think buccal, you think cheek, you always think buccal. So these are really pretty much what they're about. It's about the muscles inside the infratemporal fossa. All right, then lastly, the pterygopalatine part. The only things you're going to worry so much about is PSA and maybe infraorbital. These others you'll get at another point in time. I just don't think I can worry about them for the exam. So this is pretty straightforward. Just know how you divide the artery up and the branches of those different parts. It should be straightforward. I put this on here, just kind of the same thing. So I highlighted about, remember for the pterygoid part, things like buccal artery. The buccal artery is going to follow. It's on lab-wise. I think that's why I put this on there as much as anything. So here would be, that's not it. Up here somewhere should have been long buccal nerve. And from there, you would see the buccal artery going the same thing, going down to where the buccinator would be. I don't think that you'll really see some of these other branches. PSA you would see for sure, but things like mesenteric or pterygoids, I wouldn't worry about. The other ones I want to point out are these two arteries right here. These are the deep temporal arteries. You're always remembering the deep temporal is going to be these branches that come off. They don't dive down into the infratemporal fossa. They're actually going to go up above the boundary. So here's the infratemporal crest right here. Here's greater wing of the sphenoid. So the deep temporals come off and travel above the boundaries, superior boundary of the infratemporal fossa, and then travel deep to the temporalis muscle. Remember, deep temporal arteries are branches of the maxillary artery. Superficial temporal arteries are not. The superficial temporals are branches of the external carotid. Remember, they're one of the two terminal branches, maxillary artery, superficial temporal. Deep temporal, branches of the maxillary, superficial temporal, directly from the external carotid. If you see nerves traveling up in the same area, it's going to be deep temporal nerves coming from V3, going deep to the temporalis muscle, hence they're going to be motor muscles to the temporalis muscle. This nerve that you see coming up and going superficial to the temporalis goes posterior to the condyle, it'll give off innervation of TMJ. Here's the auriculotemporal. So auriculotemporal is going to be a sensory nerve. Deep temporal will be motor nerves. I'll talk more about nerves in just a minute. So on here, he lists where these different parts of the maxillary artery give blood supply to. So no, mandibular part, I'm saying no, K-N-O-W. Know that the mandibular part goes to the, areas of, maybe it goes up on another side. But what's it going to do? It's going to go to teeth, mandibular dentition, and it's going to go to ear. You can think of the branches, meninges, that sort of thing. The pterygopalatine part going to other places, buccal part going to muscles. Okay, just to emphasize again about middle meningeal being a branch of the first part, traveling through the loop of the auriculotemporal nerve. You're also going to make sure you remember that the middle meningeal travels through foramen spinosum. So middle meningeal is a big one to always remember about. Let's see, sorry. All right, so nerve supply to the fossa. I highlighted multiple things on here. You gotta make sure you know multiple things. So remember, V1, trigeminal, V1, V2, V3. You must always remember, V1 is a purely sensory nerve. So that means any of its branches are purely sensory. V2 is a sensory nerve. Its branches are sensory. V3 is a mixed nerve, motor and sensory. So from V3 will be sensory branches, some motor branches, and then one primary nerve you remember is a mixed nerve, motor and sensory, that being inferior-alveolar. I'll talk more about that in just a minute. So V3, what does it do? It travels through foraminal valley, comes into the infratemporal fossa. It gives off 4 primary sensory branches: inferior-alveolar, lingual, long buccal, auriculotemporal. And we'll talk a little bit more about those. Okay? V2 does have some connection to the infratemporal fossa. You don't find it inside the infratemporal fossa. Remember, it goes through foramen rotundum, goes into the pterygopalatine fossa, but it gives off a branch that you will find going into the infratemporal fossa, that being the PSA nerve. Okay, so one thing I wrote up here, and make sure you remember, is that V3 provides sensory innervation to all of the mandibular dentition. All mandibular teeth are innervated by V3, and particularly by the inferior alveolar nerve. It does all mandibular teeth. The maxillary nerve innervates all maxillary dentition, but it does it by 3 specific branches: PSA, MSA, ASA. Posterior superior, middle superior, anterior superior. The one that you've kind of seen more than anything else is PSA. PSA gives innervation to the the maxillary molars. All except for one cusp that we'll get to and we'll talk about soon enough. All right, so when you think teeth, V3, particularly inferior alveolar for mandibular, V2 for maxillary, and it's going to be split up into 3 branches. Okay. So here, we talked about there's V1, those 3 primary branches we talked about before. So here's V2 going through foramen rotundum, goes into the pterygopalatine fossa, and it gets off this branch that comes back out the pterygomaxillary fissure, the PSA nerve. PSA going down to maxillary molars. I think that's all I want to talk about for that. Okay, so I mentioned about V3 going through foraminal valley. So let's talk about those 4 sensory branches. Remember, there's one first branch, no, I won't say first branch, but a branch that comes off called the long buccal. Sometimes you might see called the buccal. I don't like thinking buccal branch because I want you to think buccal branch. You see branch, you think facial nerve. So a long buccal nerve, or buccal nerve, if you will, is a sensory branch coming off from V3 that's going to be sensory to the cheek, skin covering the cheek, the buccal mucosa, and some buccal gingiva. A key point, I'll show this on a slide in just a minute, a picture slide, is the fact that it travels between the 2 heads of the lateral pterygoid muscle. Sorry, I put it in that color. I could see it on my computer. I didn't think about y'all not being able to see it. So the long buccal nerve passes between superior and inferior heads of the lateral pterygoid muscle. That's a must know. And that's going to help you lab-wise as well. I'm going to go to the next slide and I'll go back to this one. So when you look, here is superior head, here's inferior head. There's the long buccal nerve coming out between the 2 heads, going right over to where buccinator is located at. To do the skin out here, it would go through the muscle, go inside, do buccal mucosa, buccal gingiva. So between the fissure, if you will, of the 2 heads of the lateral pterygoid is the long buccal nerve. Alright, so next we'll talk about lingual nerve. So lingual is a branch of V3. It's a purely sensory nerve that's going to go to provide sensory innervation to the anterior 2/3 of the tongue, floor of the mouth, lingual gingiva. Lingual nerve. It's going to be used by parasympathetic fibers to hitchhike onto that I'll talk about in just a minute. It's going to be chordae tympani hitchhiking onto it. So chordae tympani from the facial nerve will hitchhike onto the lingual nerve. And remember, chordae tympani does two things. It's taste, special sensory taste from the anterior 2/3 of the tongue, and then also preganglionic parasympathetic fibers go into the submandibular ganglion for salivation. All the salivary glands, if you will, except for parotid. Okay? So chordae tympani hitchhikes on.
What was the second part? After anterior 2/3 of the taste?
Preganglionic parasympathetics to the submandibular ganglion. So when you look at this slide, that was not going to show up. Let's see if I got one. I might not have one in here. I have to find another slide. But you can, it comes in from posterior, chordae tympani comes in back here, hitchhikes on, and the ganglion sitting like right down here. So preganglionics to the ganglion, postganglionics come off and go to submandibular, sublingual gland, a bunch of small, minor salivary glands. So remember, preganglionics go this way in chordae tympani, special sensory taste go this way. Okay, lingual, whoops. The inferior alveolar nerve, you need to remember, when it originates from V3, is a mixed nerve. It's a motor and sensory nerve. And then what happens is, right as it gets to the mandibular foramen, it will split and give off nerve to mylohyoid, which will then carry the motor component of that nerve. And then it stays inferior alveolar as it goes into the mandibular foramen. It is a purely sensory nerve inside the mandible. Now, know that inside the mandible, what's going to do anything but putting it. So here's inferior alveolar. It goes into the there's the little nerve to mylohyoid right there. It does not go into the mandible. It bypasses the mandible, going to the two muscles over here, mylohyoid, anterior digastric. And then inferior alveolar travels within the mandibular canal, and right about here where it's cut off, it will split into its two terminal branches. Mental, coming out the mental foramen to be sensory to the skin of the chin, the lower lip. And then inside the mandible, it continues on as a nerve called the incisive nerve. That will be sensory to basically the mandibular incisors. So just for your purposes, because we'll talk more about anesthesia later, understand that the point where you do an injection, you give anesthesia, you numb the nerve always distal to that point of injection. That's why when you anesthetize an inferior alveolar nerve block, you hit the nerve back here, don't hit the nerve, you anesthetize the nerve back here, so everything this direction will be numbed. So all the mandibular teeth on one side, skin of the chin, the lower lip. That's why if you want to find out if the patient's numb or not, take a little Explore or something and just touch the chin. Can they feel it or not? Touch the lip. Does your lip feel fat? Yes. Can you feel this? Nope. You're numb. Let's go. All right. So inferior alveolar. But remember, right here, it would be a mixed nerve, motor and sensory. Here, it's a purely sensory nerve. Nerve to mylohyoid is a motor nerve, not sensory, typically. Doesn't mean it can't be, but for your purposes, it's a motor nerve. Now, one point I want to bring up since talk about both lingual and inferior alveolar is these two nerves travel between the fissure between the inferior head of the lateral pterygoid and the medial pterygoid. So out of this fissure right here come these two nerves. Long buccal was between the fissure between the two heads of the lateral pterygoid. Inferior alveolar, lingual come out between the fissure between, inferior head of the lateral pterygoid and medial pterygoid. The one sensory branch that you don't see relative to these muscles is auriculotemporal. Here's auriculotemporal back here. It lies deep to all these muscles. It's the only branch that's traveling posteriorly. These other branches are really traveling in an anterior direction. Auriculotemporal will travel posteriorly. It's going to travel posteriorly, go deep to the ramus of the mandible, travel up, give innervation of the TMJ, auricle of the ear, and then up onto the scalp. You know it has its little loop through which middle meningeal artery will travel through. That should all be stuff I'm talking about on here. So, that. Now, this thing on here, I want to make a point about this because he has on here in the notes that it's secremotor to the parotid gland. That's not completely true. It carries secremotor fibers, part of its pathway, that will go to the parotid gland. But if you were to cut the auriculotemporal nerve at its origin from V3, you would not affect parotid secretion one bit. Okay? Because V3 has nothing to do with parasympathetics and with secretion. All right? I'm sorry, I don't have the slide. Oh, this will work. So what happens is, here's where the otic ganglion is. So typically what's going to happen, so this is the pathway that those fibers take. This has a little bit to do with the ear. So here, good, I've got this on it. So here's the facial nerve. Here's the facial nerve going through the facial canal. Here's where porta tympani comes off, travels back up into the middle ear, goes between malleus and incus inside the middle ear, goes across, and as you know, goes out the petrotympanic fissure, and hitchhikes onto the lingual nerve. So this is why I say the lingual nerve is a purely sensory nerve. If you sever the lingual nerve right here, all you affect is sensation of the lingual nerve. All these fibers are still intact and work perfectly. Same with the auriculotemporal nerve. So what happens is, here's the otic ganglion. So here's going to be the lesser petrosal nerve. It also comes in and goes through foraminal valley, goes to synapses in the otic ganglion, and then postganglionic fibers will come off and jump onto the auriculotemporal nerve. And usually it does it somewhere down around here on the loop or whatever. So if you sever the auriculotemporal nerve here, you've not affected salivation from this whatsoever. If you sever auriculotemporal nerve out here, you'll affect both sensation and autonomic function. Okay? So hopefully that makes sense. Here's the inferior-alveolar nerve. So right here is where nerve to mylohyoid exits off. Inferior-alveolar nerve right here is a mixed nerve, motor and sensory. Right here, after this nerve has come off, going into the mandibular foramen, it's now a purely sensory nerve. Here's its motor component, going over to mylohyoid and anterior digastric. Does all that make sense? Excellent. Okay, so always trying to point out this is the glossopharyngeal nerve, cranial nerve 9 is parasympathetic to the parotid gland. So remember, there are two cranial nerves that provide parasympathetic innervation inside the infratemporal fossa. And really, if you want, going for salivation, facial and glossopharyngeal. Chorda tympani carries preganglionic parasympathetics. Lesser petrosal carries preganglionic parasympathetics. Chorda tympani from 7, lesser petrosal from 9. Okay, let's keep going. Okay, so I think that got me through infratemporal fossa. We are now moving on to some other areas. This is, maybe I'm still some of the same thing. Got ahead of myself. Nope, I'm not. All right. So going into TMJ, so here's the mandibular fossa where you know the head of the condyle sits. So there's a couple of bony entities and structures that he makes a big point about, so you're going to make sure you know about. Mandibular fossa is bounded anteriorly by the articular eminence, so the eminence would be what's going into the screen from this view. And then here's the postglenoid tubercle, this pointy thing right back here. And then inside is the petrotympanic fissure where chorda tympani has its exit. Okay. So again, here's one of the slides. It's got multiple things to it or whatever. So for, this kind of is for TMJ, but really it's about muscles of mastication as well. Anything related to a muscle of mastication where there's a point, an information, wherever, know that. Know everything there is to know about origins, insertions, actions of the muscles of mastication. Hopefully everybody knows they're all innervated by V3. If you're a muscle of mastication, you're a V3 innervation. So know things like superior head of the lateral pterygoid has an attachment to the capsule, the articular disc, and a little bit of its fibers go to the pterygoid fovea. Most of the pterygoid fovea is going to be via the inferior head. And its function is basically to help keep position of the disc as you open and close. I did this as well, talk about mandibular fossa is not for articulation. It's really the articular eminence that's going to be about this sort of thing. So I guess what I would say is for the test, because don't do this for the oral biology test, because I don't agree with this slide and I know this is not true. There is cartilage relative to the disc. 100%, no ifs, ands, or buts about it. There's cartilage in the articular disc, especially of, as you can imagine, older individuals I talked about. Okay? Fibrous connective tissue, not cartilage. It forms the disc initially, but it becomes fibrocartilaginous as we age. So for the oral biology test, you better know it that way. I don't think it's going to be a concern for this test. I just saw that on there and had to make a point of that or whatever. It also helps if you spell retrodiscal with a C instead of a K, but one of my quibble.
Wait, so what do we need to know for this test?
I wouldn't worry about if there's cartilage or not in the disc. Okay? For your purposes, you can think the disc is all fibrous connective tissue. Whatever. Okay, so a couple of things. Points on this slide about the retrodiscal tissue is, so if you stretch the pad too far, obviously that would put the pad on top of the head of the condyle, or if you compress it too far posteriorly, if the condyle moves back and is pressing on the retrodiscal tissue, you may cause pain, inflammation, and swelling. Also, if you have enough swelling that gets to where it displaces the condyle anteriorly, you can cause malocclusion. I have to go along with this because it's in the slides and he made a big deal about it. I'm not going to say, I'll just show you. I don't know if y'all will get Dr. Hoopengarner in any of the classes. He does a lot relative to occlusion and other things for CE courses here at the school. He would be jumping up and screaming if he saw this, that we teach this. Oh well. Make sure you know, as I mentioned, muscle attachment. So the inferior head's going to the neck of the condyle, particularly the pterygoid fovea is the name of that structure on the neck of the condyle it goes to. And it's going to help with moving the condyle. I'll talk more about that function in just a minute. Anyway, know that information about muscle attachments that's on there. Okay, the lateral ligament, or what's called the temporomandibular ligament, it has a couple of functions to it. So some of these fibers can be function to resist posterior movement and protect the retrodiscal pad. So what prevents the retrodiscal pad from going too far posteriorly? That would be it. That's part of it. So it also helps prevent that retrodiscal pad from being compressed upon. So it acts as kind of like the sling on the posterior part of the mandibular condyle such that the condyle can't go too far posteriorly. The other thing it does is it's also what tends to help prevent the condyle from being dislocated posteriorly. Okay? Even though yours truly showed you some slides that shows you that this can't, but the disc can't. Never mind. Lateral ligament, strong reinforcement of the wall. Yeah, so it reinforces the lateral aspect of the capsule, prevents posterior displacement of the condyle. Probably what all this says on here. So two structures help prevent the condyle from being displaced laterally. That's the lateral ligament and then the contralateral medial wall. So basically where the bony structures are medially, remember they prevent medial if you will, dislocated. They prevent the condyle from being moved too far medially, which hence prevents the opposite side from being moved too far laterally. Does that make sense? If I can't move one side too far medially, I can't move the other side because they're connected. So if you can't push in this side, it inhibits this side being forced out. Okay, so, man, I emphasized that twice. I must have thought that was important. All right, so he also made emphasis, and I know this is one of those things he always likes about is remembering that you have two collateral ligaments that attach the disc to the medial lateral poles of the condyle, and so the disc is tethered to the condyle in a medial lateral direction. Remember that means it can move in an anterior posterior direction. It's not really moving medial lateral. So it allows it to move in an anterior posterior position. But what happens is if you get damage, rupture, if you lose the attachment, or if they get weakened or whatever, these attachments, what that tends to do is allow the disc to move too far anteriorly. So when you think about maybe anterior dislocation, or particularly you talked about clicking. When you think about clicking of the TMJ, oftentimes it's because the disc moves too far anteriorly. What allows the disc to move too far anteriorly is weakening of the collateral ligaments or detachment of the collateral ligaments or something of that nature. Okay? So when you think about clicking, think collateral ligaments. Think about anterior dislocation, think about collateral ligaments. The spine of the sphenoid is a structure that strengthens it medially, I mentioned a moment ago. So the mandibular fossa itself and the spine prevent this from moving too far medially. That's what I'm talking about, not allowing for too much lateral on the other side. Okay, so if the condyle will dislocate, it's going to do it in an anterior direction because you have things that prevent it from going medially. We just talked about mandibular fossa, spine of the sphenoid. Until we won't dislocate laterally because of the temporomandibular TMJ or lateral ligament and the capsule. Until he's not going to be allowed to go too far posteriorly because of things like the postglenoid spine. So usually the only way that it can dislocate, if it will, is going to be an anterior direction. So when a patient or somebody gets in an open lock, remember it's because that head of the condyle slid and went across the articular eminence and gets locked in that anterior spot. All right, they're not going to get locked in another direction, just anteriorly. All right, so I think you probably even had this in occlusion as well or whatever. So remember, the condyle has two movements associated with during opening and closing. It's called hinge or rotation, or sliding, which is translation. I always teach this rotation, translation, but rotation is a hinge movement, translation is a sliding movement. So basically it's the condyle rotating in place, right? It rotates, and then as it moves in an anterior, posterior direction, that's translation. Now, you must know, so you have the head of the condyle, the disc above it, and then above the disc is the articular eminence, the temporal bone, if you will. So you've got an inferior joint compartment, a superior joint compartment. So rotation is always between the head of the condyle and the disc. It's a movement in the inferior joint compartment. Translation's the kind of opposite of that, if you will. Translation always occurs between the disc and the temporal bone. So translation always occurs in the superior joint space or joint compartment. So something that would occur in one of those joint compartments will inhibit one of those motions. If you had something that's, blocking, or the easier thing is, what typically happens is adhesions between the disc and the temporal bone. So what's that going to typically inhibit? Translation. If somehow you had something that was occurring within the inferior joint space, what movement would be inhibited? Rotation, hinge, if you will. Okay? Another thing Dr. Huppengarner would just love. I know he made a thing about the first third is hinge rotation, the middle third's a combination, the last third is translation or whatever. I don't know what to tell you. Other than it's dead wrong. But, and it's, the thing is most people who, you know, especially people who teach inclusion, things will tell you, it's not a matter of what's important. It's not a matter of, you know, they always used to teach the first 8 millimeters of opening was hinge, and then this amount of, you know, so I was taught that way for the longest time, and we now know that, you know, it's just not the case. And so, I shouldn't be saying anything. So again, here's what I put in here. So pure translation is all between the disc, disc and the condyle. The main thing about it is it's sliding across the temporal bone. Remember, translation is all about the superior joint compartment. Rotation is all in this compartment, the inferior joint. There's no rotation in the inferior chamber. What? Oh.
calls it the chamber in
I think
Still
it's
the-
all
still
those
stays.
ones.
Oh, it's in the,
It's still the joint chamber.
okay.
That's what you call
No, I
it.
think it's because he's talking about impure translation, that like there will be no rotation.
You know, and, okay.
Because I thought it was more impure.
So here's, you know, so let me give you an example of what pure translation would be. If you're sitting with your teeth in, with your mouth closed, your teeth in occlusion, if you jut your jaw forward, if you protrude your jaw and then pull it back, that's translation. Okay? You're sliding the mandible forward, sliding the mandible back. Okay? That movement would occur with no rotation whatsoever. Okay? So that's kind of what we're talking about there. But, you know, when you put your hands up there and you open, I mean, you're going to feel rotation, translation. Oh, I know why I put this on here. So this is a case of where if somehow the mandible got in an anterior dislocated position. So here's the articular eminence back, you know, through there. Here's the head of the condyle in an anterior lock. All right. So what would you do to get this out of this dislocation? So to reduce dislocation, press inferiorly and posteriorly. Now that's really easily said. That's not necessarily easily done. A lot of times you're going to do something to maybe anesthetize the muscles, get them to relax such that you can do it. Because oftentimes when somebody comes into your office who's in this position, they've been this way for a while. These muscles have gone into spasms. It makes it sound, oh, it's easy, just take the mandible and pull it down, and it's not as easy as what that makes it sound. Oftentimes it takes a lot of force to be able to do that, and it will hurt. So just know that's how you get somebody out of this anterior lock. Press inferiorly and posteriorly. Oh, here's what I'm talking about with the collateral ligaments relative to anterior dislocation. Well, the disc makes support. It's like a watermelon seed. Know that the primary innervation for the TMJ is the auriculotemporal nerve. We teach it that so there's some other nerves nearby, like masseteric and temporal nerves that can have some, those are primarily motor nerves though. They can have a few sensory fibers. It's mainly auriculotemporal and then a couple of other ones that can. I don't know why I put this one on there. Okay, let's go to muscles of mastication. All right, so the slide coming up, I think this one. Oh, you're going to know everything you can about origins, insertions, actions. You know their innervations. B3. Make sure you remember buccinator does not share an innervation. We lump it in with the muscles of facial expression. It's innervated by the facial nerve. Anterior digastric and mylohyoid aren't muscles of mastication. They will assist in opening the jaw. They can aid in a couple different processes, but they're not ones that have their primary origin. They really originate from the mandible, then insert onto the hyoid bone, whereas the true muscles of mastication are all about inserting onto the mandible. That's why they move the mandible. Masseter having two heads, so make sure you know that the the superficial head is one that can be involved with retrusion. Oh, that's deep head. No wonder, sorry. Anterior head is going to be involved with protrusion. Deep head can help a little bit with retrusion, but I want you to know the primary muscle that's involved with retrusion of the mandible is the temporalis muscle. I mean, look at all these fibers going this posterior direction. Here's origin back here, here's this insertion over here. So the primary retruder of the mandible will be temporalis. These fibers can help assist with retrusion, but this can be all about retrusion. Pulling it up, anterior part can help a little bit with protrusion. But in the same vein, when you think protrusion of the mandible, the primary protruder of the mandible is actually the inferior head of the lateral pterygoid muscle. Jaw opener, and it protrudes the mandible forward as you open. When you close, you have to retrude back, a little bit by masseter, but primarily by temporalis. Okay, so anything on here that gives you a bony structure that attaches to, make sure that you know. So one thing for the masseter, the most powerful elevator of the mandible, which is true, but you're going to remember that you talk about the pterygomasseteric sling. Okay, so remember, there's kind of a connective tissue sling that attaches, kind of connects the masseter superficially to the medial pterygoid deep to the ramus of the mandible. So those two have a little sling of connective tissue that connects them, and so they act together as kind of a muscle in unison to elevate the mandible. Masseter is the more powerful of the two, but I want you to understand that it forms that pterygomasseteric sling with the medial pterygoid for elevation of the mandible. Temporalis, I mentioned about being for protrusion. Also remember, it's the muscle most responsible for intercuspation. Why? I don't know. But there must be a fact. So I've got all this stuff on here, just reminding everybody about the origin insertions. All this information is fair game. It is all important relative to what he does. He makes a big point about temporalis relative to seating dentures. So make sure you know the fact about denture base lies on this tendon of the temporalis. So if it flexes, it may flip the denture out. That is an important fact for you to know clinically, because it does have to do with how you actually seat a denture, and when you manufacture it, being aware of the position of this tendon such that you don't get this to occur. Most know origin insertions and actions. Make sure you know that. The reason I put this slide in place, so most of these muscles are going to act to either elevate or depress. So the only muscle that really acts to open the only muscle of mastication, that's really acting for jaw opening is the inferior head of the lateral pterygoid. Masseter, temporalis, medial pterygoid are all jaw closers. Inferior head is a jaw opener. It also acts to protrude the mandible. All right, but the other thing I want to point out is he has a slide here that talks also about side-to-side movements. So if you're a muscle that's on the outside, superficial side of the mandible, you can move the mandible to the same side that you're on. So masseter, right masseter, will move the mandible to the right. Okay? Think about its directionality, how it's positioned. Origin up here, insertion down here, so when it contracts, the only thing it can do is pull to that side. It doesn't do a ton of side-to-side movement. Temporalis, same thing. Really doesn't do much side-to-side movement, but it would function that way. Look at the position of the medial pterygoid in this picture and of the lateral pterygoid. If you're a muscle that attaches on the inside, the inner deep aspect of the mandible, you will move the mandible to the opposite side that you're on. So if I am right medial pterygoid, I move the mandible to the left. If I am left inferior lateral pterygoid, I'll move the mandible to the right. The pterygoid muscles are the primary movers of side-to-side movement. I know we talked about the zygomandibularis and sphenomandibularis. I don't think you got to know anything about those. Most of us who are anatomists consider them to be bogus muscles. Somebody trying to get their claim to fame. So this is all just trying to show you different things. So here's kind of that pterygomasseteric sling, medial-pterygoid masseter, primary for elevation. Temporalis is another, elevator, jaw closer. Lateral pterygoid is going to be the jaw opener, working with anterior digastric. So you can see how things move certain ways. Protruders are going to be primarily lateral pterygoid, a little bit of masseter. Retruders, primarily primarily temporalis, a little bit of masseter also. But you think primarily retrusion, temporalis. The main protruder, lateral pterygoid, inferior head. And this is trying to show you side-to-side movement. Muscles inside move opposite the side they're on. The muscles on the outside move to the same side that they're on. Let's see. Okay. Lastly, and I'm trying to get this finished up. Man, there's a ton of information in there about ear, but I know that I will hit some highlights here. Okay? So, let me go back. Make sure you know about what all the different nerves were that were providing innervation to the external part of the ear. So there's a whole host of things on here as far as things like V3, 10, and then a lot of it was relative to the tympanic membrane. I don't know that she talked about the Q-tip in the ear or whatever, or cough reflex, right? So that's why sometimes you put a Q-tip in your ear. Why do you cough when you do it? Because you're stimulating the vagus nerve. Vagus nerve is all about cough reflex. Okay, so make sure you know that cranial nerve 10 provides a little bit of innervation inside of here, so that's why you get cough reflex relative to that. Blood supply to the external ear is going to be by primarily the posterior auricular branch that comes off the external carotid. Superficial temporal will give a little bit of blood supply as well. So those two things are the primary blood supplies to the external ear. All right, so you know that the process of hearing begins at the tympanic membrane. Vibration of the membrane then sets off a chain of reaction through the 3 ear ossicles, which will then set off a chain of reaction inside the inner ear. So first off, you have to understand that on this tympanic membrane, there's a convexity called the umbo. And then on the umbo, this portion here, the handle of the malleus attaches to where that umbo is located at. So here's the handle attaching to the tympanic membrane. So when the tympanic membrane vibrates, it's going to vibrate the malleus. The head of the malleus will then stimulate the incus. Incus then will stimulate the stapes. The stapes will then transmit information to the oval window and then cause a whole chain of reaction inside the cochlea. So this whole process of sound waves begins at the tympanic membrane, goes through the 3 ear ossicles to the oval window, and then sets off what's going on inside there. Remember the foot plate of the stapes, I've seen the word articulate, however you want to think about it. It basically sits on the membrane covering the oval window. The round window does not have a bony structure to it. There's a membrane covering it. Okay, so I think this is all just the same thing. Again, tympanic membrane, malleus, incus, stapes, which set off this chain of reaction. All right, so there's 2 skeletal muscles associated with the ear ossicles. And so one of the things you have to remember about that is that means that there are 2 different innervations associated with movement of the ear ossicles, or if you will, controlling movement of the ear ossicles. Tensor tympani is innervated by V3. Tensor tympani attaches to the malleus, and then stapedius, innervated by the facial nerve, attaches to the stapes. So a problem with either tensor tympani, I think the next page I got, or stapedius. So if you affect V3 or affect 7, you have the problem of potentially having ringing in the ears because you can no longer dampen sound at the tympanic membrane and in the oval window. So these little muscles act to prevent over vibration of these 3 ear ossicles. okay? But tensor tympani from V3, stapedius from the facial nerve. So hyperacusia, can't respond to loud sounds. Okay. So in her slides, she had multiple slides that were summaries of the middle ear, and so it's knowing what's part of the different walls. So make sure you understand the roof of the middle ear is all about what's called tegmen tympani, thin plate of bone, is part of the temporal bone. The floor basically is relative to where the jugular fossa and the internal jugular vein is passing by. So I guess the things I would say that are associated with different walls that she emphasized on these slides. So then you get into like the anterior wall. Anterior wall is all about where the internal carotid artery would be, opening for the auditory tube, and then the tensor tympani muscle coming through. The posterior wall is all about the mastoid air cells. So here's the opening that goes from the middle ear into the mastoid air cells, or mastoid antrum. The antrum is the opening, if you will, add this opening into the antrum or space for the air cells. Stapedius, this tendon comes through the posterior wall. Going over here is medial wall. Yeah, medial wall. So one thing you always got to remember here, this bulge right here is something called the promontory. Sitting on the promontory is this plexus of nerves called the tympanic plexus. And what's going to come from that tympanic plexus is going to be the lesser petrosal nerve, or cranial nerve 9. Remember, a lot of this is about preganglionic parasympathetics going to the parotid gland. And then where the promontory is, sitting superior to it would be the oval window. Inferior to it would be the round window. These sit kind of medial, posteriorly within the orbit. So I would know the stuff that's on these different summary slides from that. Laterally, it's all about the tympanic membrane. Okay. Yes?
Would she make a questions like damage to this wall would cause which of the following and list off like things, problem with the muscle, problem with the arteries?
If you didn't hear the question was damage to a particular wall could potentially lead to which of the following? Potentially. I think you can look at it a couple ways. Damage to the medial wall of the middle ear would affect all the following structures except, so it'd be knowing, or could affect which of the following structures. So it'd be a matter of knowing which structures will be found on medial, anterior, posterior, whatever. And then you can also see, if you know, here this thing goes hand in hand. If you know what's on the walls, you know it will be affected. So I don't think it's to a level that you got to worry about, is what I would say. These are Dr. Wynn's questions. You will love her questions. I think Dr. Warren, I think it's going to be a very straightforward exam. There's just a lot of material. So a couple of things. So external auditory meatus, it's all about knowing its innervation and things of that nature. Internal auditory meatus was knowing about what structures travel through there. So you know that you've got cranial nerves 7 and 8. So both those travel through the internal auditory meatus. The reason I put this point up here as well was to emphasize, don't think that cranial nerve 8 then travels through the pathway or the facial canal of the facial nerve, because it doesn't. Because it's not going to do what the facial nerve does. They go through the same opening, but here's 8 going this direction, right over here to where the cochlea is. 7 is going to go down like that. It's going to eventually stylomastoid foramen. So they both go out the same opening out of the cranial cavity, but they don't follow the same pathway once they're inside the temporal bone. All right, then inside the inner ear. So you know that the tympanic membrane serves as a boundary between external ear, middle ear. So between the boundary really between the middle ear and the inner ear is kind of that medial wall. So think about where like the oval and round windows are, the promontory. Those are really kind of the boundaries between going from middle ear over into inner ear. And really to go into inner ear, you're going through the oval and round windows to get into the inner ear. So going in there, there's different structures inside of there, so it's a matter of knowing the difference between the cochlea, the vestibule, and the semicircular canals. you know the cochlea is basically the auditory part. So if you think about being vestibulocochlear nerve, so part of that nerve is going to the cochlea for hearing, part of that nerve is then going to the vestibule, and if you will, relative to the semicircular canals for maintaining equilibrium, balance, that sort of thing. So here is the semicircular canals, those are 3 of them for lab purposes, whatever. The vestibular apparatus kind of connection between, and then here's the spiral for the cochlea. That's going to be all about different structure. We'll talk different things in just a minute. So I would make sure that you know that the bony labyrinth itself is filled with perilymph, not endolymph. We'll talk about endolymph in just a minute. So don't get confused about the difference between them. Bony labyrinth, perilymph, and we'll see endolymph in just a minute. So I don't know if I need to talk about that at all. So anyway, the bony labyrinth, perilymph, and then you get inside the membranous labyrinth, which is where the endolymph would be located at. So it's the difference between what these different things you're trying to do. So purpose of those fluids is stimulating different receptors, whether it's auditory or vestibular receptors, stimulating hair cells, if you will, such that we can detect different types of things. And there was a whole big section on about that. I would know it pretty superficially, and you're going to be in really good shape. Make sure you know that within that membranous labyrinth, there's 2 structures called the utricle and the saccule. Make sure you know that both these structures are involved in responding to head position with respect to gravity and linear acceleration. And that together, you know, they're called the otolith organ, and they contain the little macula that has the hair cells for basically sensing this or whatever. So read the stuff on this slide about the inner ear and the vestibular apparatus, you'll be in good shape. So multiple slides on this vestibular apparatus. Read through those, and you'll be in good shape. Last, I think might be one of the last things. For inner ear, she emphasized about the organ of Corti, and you're going to make sure that you know that it sits on the inner surface of the basilar membrane. This is receptor for hearing. You know about that. So read this slide. Know what's on this slide. It's important information. This slide, so there's 2 slides about cochlea, inner ear and the cochlea. One was about knowing the basilar membrane, its function and purpose or whatever. And the second slide was all about knowing the different canals going through there for either the scala vestibuli, scala tympani, and the duct itself. I think if you just kind of are familiar with the basics of these structures, scala tympani, perilymph, the cochlear duct, for the endolymph or whatever, I think you're okay. I think that's should be it. I'm hoping. Yeah, okay. I know that was a little bit longer, but there was a lot of stuff in here that I know, particularly Dr. Warner's stuff, we'll go over. I think, like I said, I haven't seen, but I think it'll be a fair test. It's just a lot of stuff. They both write really fair questions. You didn't have to be writing any of those really tough questions this time, so it should be a straightforward, no problem test. Any questions? If not, you can ask them. Let's go ahead and get